Closure. So I think the first question we should be discussed is how do we assess whether newer drugs are better than older drugs? How can we make our decision reasonably evidence-based? Well, let me remind you of a fundamental principle in clinical research, because I would like you to have this very clear when you will listen to my opponent and good friend, Dr. Ruzicka. And this is that whether a newer drug is superior, similar, or inferior to the older ones cannot be established by between trial comparisons. That is, by comparing results of trial involving the new drug and the old drugs separately. And I think that this is based on some intuitive considerations. First of all, it is clear that all the drugs, by and large, have an overall greater body of evidence. They had more time to develop evidence, and the number of trials is usually greater for older drugs than for newer drugs, and this is the case also for ACE inhibitors versus angiotensin receptor antagonists. But also, older drugs may benefit of factors that may favor a greater magnitude of the observed protective effect. Think, for example, that older drugs may have the chance or had the chance to be compared to placebo. And this is no more ethically feasible with newer drugs. Older drugs could recruit patients with higher risk and therefore a potentially greater beneficial effect of treatment. Let me give you an example of this. It's the data from the HOPE study and the TRANSCEND study, which was done as a sort of a replica of the HOPE study something like 10 years later. In HOPE, compared to the placebo group, ACE inhibitor treatment clearly reduced the incidence of cardiovascular events. A number of years later, the placebo group had the same number of events, incidence of events, that the ACE inhibitor-treated group 10 years before. And of course, with the lower number of events, you cannot expect the same effect as far as cardiovascular protection is concerned, unless you believe that treatment can give us an infinite reduction in events down to more immortality. Now, the reasons for this progressive protection of the in-trial population has no mystery. It's due to a better background protective treatment. Again, if we compare HOPE with TRANSCEND, as you can see, beta blockers were given much more frequently, Brian, and this was accompanied by a greater background protection. It could have been by chance. Diuretics were given more frequently, and this could have meant a better treatment of hypertension. Statins were almost twice as frequent in the TRANSCEND population as compared to the HOPE population. But not only this, compared to HOPE, TRANSCEND in-trial population had a much greater previous use of ACE inhibitors, which are protective drugs. So the ARB, which was tested in TRANSCEND, had to prove beneficial effect in patients who had already been protected by long-term administration of ACE inhibitor, which did not happen 10 years before. So this comes to the statement, which I think is defensible, that historical comparisons are not valid to decide about newer drugs. If this were not the case, then there would be no justification for any new drugs in the history of hypertension. By far the greatest reduction in risk has been shown in the first controlled trial on antihypertensive treatment, which has been the veteran administration study. Compared to placebo, and this was a real untreated group, the treatment available in the 60s, which was, if I remember correctly, a diuretic, hydralazine, and central agent reduced cardiovascular morbidity and mortality by 61%, something never achieved later. So how can we test whether new drugs are worthy to be introduced in the market? We need head-to-head comparisons by randomized controlled trials. And this is the procedure which is adopted also by regulatory authorities. Newer drugs cannot enter the market and be used unless they prove the validity in the context of comparisons by randomized controlled trials. So the next important question is whether this is available for ACE inhibitors versus angiotensin receptor antagonists. And indeed, comparisons in randomized controlled trials have been made. There are 6 trials in which this has been done for a respectable number of 63,000 patients. And the data have been meta-analyzed. We had done a meta-analysis a few years ago. And as you can see, no major differences appeared. If anything, there was a slight greater beneficial effect on stroke in the angiotensin receptor treated group, but I wouldn't give it too much importance. I think the message from this meta-analysis is that the two classes of drugs appear to be very similar as far as cardiovascular protection is concerned. Now, there is a limitation of evidence. 5 trials out of the 6 available trials dealt with congestive heart failure and patients surviving a myocardial infarction. And in all trials, the cardiovascular risk profile of the patients was very high. So there is no specific trial in hypertensive patients, and this, we must recognize, is a limitation. Nevertheless, in OnTarget, which is the largest trial of all, about 69% of the patients had a history of hypertension. So I think, although the evidence is not perfect, I think the evidence suggests that this may be true also in hypertension. Because in OnTarget, primary outcome, stroke, major coronary events, and congestive heart failure did not show any significant difference in patients treated with the angiotensin receptor antagonist telmisartan versus treatment with ramipril. Let me now make very briefly a few further considerations. First of all, in OnTarget, not only hard endpoints did not differ, but some other endpoints which are not as hard, but nevertheless quite useful for making decisions in clinical practice, such as, for example, incidence of new onset diabetes, incidence of new atrial fibrillation, or the nephroprotective effect. And this is quite important because, as we know, patients developing renal damage have a much greater risk of having a cardiovascular events. Now, evidence from ACE inhibitors and angiotensin receptor antagonists as far as nephroprotection is concerned is a bit heterogeneous. Non-diabetic nephropathy, only evidence comes from ACE inhibitor-based trials. And this is the case also for nephropathy in type 2 diabetes. But on the other hand, in type 1 diabetes and type 2 diabetes, which is much more frequent, as you know, well, evidence of nephroprotection comes more from angiotensin receptor antagonist studies, IDNT and RENAL. How can we conclude? We need to extrapolate here, but remember that recommendations by guidelines are largely based on extrapolation. It's not true that they are guidelines evidence-based. Well, I think a reasonable extrapolation is that nephroprotection is there and similar for ACE inhibitors and angiotensin receptor antagonists. And for sure, these two classes have a similar effect on what is believed with some disagreement, but many people believe that an important marker of nephroprotection and risk due to renal damage is proteinuria. And as you can see from this meta-analysis, both classes of drugs are effectively antiproteinuric, and the antiproteinuric effect is very similar. Then there is one last point, and I'm sure my opponent will touch this. And this is the evidence from ACE inhibitor-based trials, not from angiotensin receptor antagonist-based trial, of a reduction in all-cause mortality. And this is important for public health and the safest endpoint at all, because, of course, there is no diagnostic problem for mortality. Well, but the results depend very much on the sample size and from the inclusion of a placebo group, which makes the difference in mortality much greater. I think that cardiovascular mortality is good enough because nobody really claims that these drugs have a beneficial effect outside the cardiovascular area. That would be a daring speculation. And again, when we compare in a meta-analysis the effect on all-cause mortality in comparison studies, ACE inhibitors versus angiotensin receptor antagonists, as you can see, there was no significant difference in all-cause mortality as well. There are also other meta-analyses, of course, more classical meta-analysis, not just comparison studies. One of them, as you certainly remember, has been the one by Lowe and co-workers based on more than 350 studies, huge number of patients. And when you look at the comparison data in this meta-analysis on risk of heart failure, coronary events, and strokes, once again, it's impossible to see a significant difference between ACE inhibitors and angiotensin receptor antagonists. And this has been the case also for the meta-analysis for the collaborative group in which different drugs have been compared. For a similar reduction in blood pressure, you cannot see differences between ACE inhibitors and other drugs or angiotensin receptor antagonists and other drugs. This has been the basis for the European guidelines to be quite liberal in what could be indicated as the first choice drugs, and including, of course, without any difference in the strength of recommendation, ACE inhibitors and angiotensin receptor blockers. The principle, it was mentioned in the previous debate, is that it's quite likely that a major fraction of the benefit depends on blood pressure lowering per se, regardless how it is obtained. And there is quite a good reason to be liberal, provided that the different classes have evidence of cardiovascular protection, for allowing physicians to make a wide choice, because this increases the chance for the patient to have blood pressure control. It is interesting that the same principle has been supported in the recent JNC8 guidelines, more or less the same statement as used in the previous European guidelines. Finally, having said this, do I mean that ACE inhibitors and angiotensin receptor antagonists are indistinguishable? Well, not necessarily. Mechanism of actions are not entirely superimposable. There is the bradykinin effect for ACE inhibitors, but not for angiotensin receptor antagonists. On the other hand, angiotensin receptor antagonists may have somewhat different mechanisms because of the involvement of AT2 receptors, or because of some effect of the elevated plasma renin levels. But let me say that these are just experimental data and not entirely consistent either, because there are also studies showing that bradykinin can have an adverse effect, not a protective effect, and no clinical data, of course. So whether the two drugs can be different and can show clinical differences in some situation seems to me to be a matter for research, not a matter for decision in clinical practice and recommendations by guidelines. Thank you for your attention.